I'm Steve Johnston, co-founder of A Race Against Blindness. Our mission as a nonprofit is to provide awareness, advocacy, and help fund sight-saving research. As a part of our awareness and advocacy efforts, I'm excited to share with you a conversation with Dr. Brittni Scruggs, a vitreoretinal surgeon at the Mayo Clinic who has fascinating information about inherited retinal diseases and future treatments. I hope you find this educational and informative. So it is really exciting to have you here today to learn about your expertise and your experience treating patients with these ultra-rare eye diseases and to learn about some exciting updates pertinent to the Bardet-Biedl community. So can you tell us a little bit about who you are, your background, and your expertise?
Yeah, thanks for having me. I appreciate the invitation. So I'm Brittni Scruggs. I am from New Orleans. And I did my MD and PhD in New Orleans at Tulane. Okay. So I was in the joint program there. My PhD was in regenerative medicine, focusing on stem cell and gene therapy for neurodegenerative diseases.
Okay.
So at that point, I wasn't going into ophthalmology. That was not on my radar. And I was more interested in neurosurgery.
Okay.
Yeah. So I did stem cell therapy and gene therapy for mostly pediatric leukodystrophy models, mouse and macaques. Mm-hmm. And it was from that work that I became interested in ophthalmology because those disease states often lead in pediatric blindness. Okay. So after my training, medical school and graduate school, I ended up matching into ophthalmology residency to pursue retinal regeneration work. And I matched to University of Iowa, where there are many leaders in the field in gene therapy and stem cell therapy, inherited retinal diseases. And so it was an honor to match at that program for 4 years, remained in the lab and working with them at clinic in the operating room and the bench laboratory, really understanding how to do this as a career, and then launching my own career. I went to Casey Eye Institute at Oregon Health Science University in Portland, Oregon, to further my training as a gene therapy surgeon and as a vitreoretinal surgeon. So I am an adult and pediatric vitreoretinal surgeon. My clinic week is full and rewarding. Ranging from operating room days, 1 to 2 days a week. I'm in the OR performing cases, both children and adults. Okay. I have protected time for inherited retinal disease clinic where I see pediatric and adult patients with presumed inherited retinal diseases of all forms. And then I do research. I have protected time in the lab where I am one of the investigators in the Mayo Retinal Regenerative Medicine Laboratory. And so leading efforts with my collaborators, we have graduate students and technicians, fellows, residents. So as a clinician, surgeon, scientist, it's a full career, and I'm so grateful to be here.
That is a busy, rewarding set of things that you're doing. So first off, I'll say thank you because that is such a important need in the world and from our community standpoint of rare diseases, needing true specialists like you. So thank you for what you're doing. I have a reverse med school question for you. So like the old question of like, why do you want to be a doctor? What got you here? So you are a subspecialist of, ophthalmology is a subspecialty of medicine, of the career of medicine. Then you are even further specialized into like vitreoretinal surgery, and you're even more specialized in your special interest in inherited retinal diseases and specifically pediatric retinal diseases. So how did you exactly come to that desire to really want to have that, that niche, and what drives that, kind of fire for you?
Yeah, great question. So it's been a windy road to get where I am, but all because of really amazing mentors, honestly. So as a PhD student, I was doing microsurgery on, usually small animals, mice. And I found that I really needed to be a microsurgeon. Like that was my passion. That's what I wanted to do. I'm good at surgery and I really enjoy it. But even more than that, I wanted to be able to marry the two of being a surgeon and a clinician, but answering questions that really require creative problem solving and science. And curing blindness is something that I saw my mentors trying to achieve on all of those different paths. Going to Iowa, I was in Dr. Stone's lab and Dr. Bud Tucker, Dr. Sohn, Dr. Hahn, Dr. Drack. All of those doctors were my mentors. And they showed me that we need to continue to pursue good science until everyone is cured.
Right.
It is a passion that I saw lived out on a daily basis. So I was really interested in working with children. And Dr. Drack was one of my main mentors in the lab in the clinic. And she really helped me pursue pediatric retina and pediatric retina surgery. And so with that, my team mentors at Iowa really encouraged me to go to Casey Eye Institute, which I was thankful to match there for fellowship. And remember along the way, none of this is guaranteed. The match process is, it's a tricky process where you kind of hope for the best. But I feel really lucky to have, landed some amazing opportunities. But at Casey, I was operating with 8 different retina surgeons, clinician scientists who were doing gene therapy. And as a fellow, I assisted on over 70 gene therapy surgeries.
Wow.
And that was over a wide range of diagnoses. Some were in clinical trials, some were Luxturna, post FDA approval. And so I was able to see those patients preoperatively, intraoperatively, and postoperatively, and kind of experience what is gene therapy, and is this something that I want to do for a living?
Wow. I mean, that's so fascinating. And I mean, it really just strikes me from hearing that is that you're one of the few people in the world who really is an expert in this. I mean, I know there's other people who are doing what you're doing, but I mean, you're kind of one of the rare ones. So can you tell us what your experience has been like in treating, patients with inherited retinal diseases just in general, and what that kind of looks like to you on a day-to-day basis?
Yeah, absolutely. So when you really ask patients who have inherited retinal diseases what their experience is, oftentimes there's a common theme of I was diagnosed and that experience was really scary, right? They were told that you're going to go blind. This is the diagnosis and there's nothing we can do for you.
Yeah, exactly.
I hear that often.
It's what we said exactly when we found out, and we have a child with Bardet-Biedl syndrome. So,
right. So, going back to the mentorship, I have seen inherited retinal disease care done a different way. And I'm empowered every day for the rest of my life to give good care in a way that empowers the patient, optimizes their vision, optimizes their quality of life. And I can't think of anything more meaningful for me as a physician than to take something that is so horrible as a diagnosis and to lean in, to give them hope, to give them something that they can actually do, whether that not that it's potentially just low vision resources or occupational therapy or different services, or just a really good education about what is going on and what is to come from a scientific standpoint. And that does take time. It takes chair time. But that's something that thankfully at Mayo, I have the opportunity to sit down and to educate and to teach. And an inherited retinal disease clinic really takes a lot of coordination of care.
Yes.
Ranging from doing the right testing, so you get the accurate diagnosis, to having a genetic counselor who can sit down and talk about the implications of the result that we're receiving and how does that play into family planning, and gene therapy and, different clinical trials that are available. All of that takes effort, time, expertise, et cetera. And so on a daily basis, I'm seeing complex patients who require that time and require me to potentially refer to various other specialties, because a lot of these inherited retinal diseases are not just eye related. Right. They also have potentially syndromic implications that require extra testing, extra care.
Yeah.
So every Wednesday is when I see patients who have presumed inherited retinal diseases. And it is such a rewarding experience to take care of these patients.
So it's, super fascinating, all the different, inherited retinal diseases that you're seeing, that you're treating. Obviously, treatment is obviously the big question mark for everybody in the community on a patient standpoint. So what are the major targets in terms of kind of, the different modalities or different types of therapies that are being looked at from a, not just for a single condition, but just for the, IRD community as a whole?
Yeah, it's a great question. I would say that's the number one question that we get as physicians who are treating IRDs. Can you cure me? Can you slow down the freight train?
Yeah. Right.
Can you stop this progression? So it really depends on the disease state, because there are so many clinical trials currently out there. Retinitis pigmentosa is the most common IRD, definitely in my clinic. And in general, if you look at the prevalence, 1 in 3,000 live births is the prevalence for RP. And so that's where a lot of the efforts are, is RP research, RP clinical trials. And so to speak to that a little bit, Luxturna is the only FDA-approved gene therapy. And so that's definitely opened the doors for many clinical trials. I think that's really important, because once that was FDA-approved, the threshold for doing gene therapy definitely was lower. The barrier was lower. So gene therapy is one broader category. And so I think it's important to kind of understand who would be eligible for something like that.
Right.
So gene therapy is essentially infecting, transducing, that's the word we use, but it's infecting cells that are present, right? So it's for patients who still have cells present, right?
Yeah.
They are not to the advanced end stage. They still have real estate that can be protected.
Yeah.
And those cells need to be functional again. And so the gene therapy is to provide the protein, the gene, that they're either missing or that's not functional in their cells. And so there are many gene therapy trials currently to date for RP, specifically X-linked retinitis pigmentosa. There are gene therapy trials ongoing for retinoschisis, for achromatopsia, big trials that were recently done, choroideremia. The list goes on. They're all still in stages where they're not FDA approved, right? So there's only one single FDA approved medication for the eye.
Yeah.
And so there are other things that we can offer, though, like here and now, that potentially can decrease that progression rate as well, not just gene therapy. And one of those is oral medications that potentially are really strong antioxidants, anti-inflammatory medications. So the thought with retinitis pigmentosa and with a lot of inherited retinal diseases is that when you have cell death, specifically like the rod photoreceptors, you have not only death of the cell, which can be inflammatory, but you also have more oxygen that is coming through that area where the death happened.
Oh, interesting.
And that increases your reactive oxidative species, right? And so that is one of the main hypotheses of why you have progression from out to in, where you have this constriction, the tunnel vision.
Yes.
Is because the rods start to die, and then the adjacent cells that are healthy are now succumbing to the same fate because they're in an environment of inflammation and oxidative species. And so then they die, and then it's this snowball effect where the tunnel just continues to constrict in. So if you can decrease the inflammation, decrease the oxidative stress, then potentially you slow down the rate a little bit. Is it a cure? No, because the cells still have the dysfunctional gene and either missing or dysfunctional protein. But that's one thing that is being tried. And so NAC, which is N-acetylcysteine, is currently being tried. It's in the phase 3 trial. And it's just an oral agent.
Yeah.
Right? So oral medication, FDA approved for other indications, of course. And the goal is to figure out, is it safe and effective for RP? Seems to have some promising data from the phase 1, phase 2 trial. And as one of the sites for the phase 3 trial, we are encouraged. Patients seem to tolerate it very well.
That's exciting.
So that's another kind of bigger category, not just NAC, but there are other agents that are being tried, but all with the same goal of decreasing oxidative stress, maybe providing growth factors that do the same.
Okay.
Stem cells, that's always something that people ask is, are there stem cells that can be given to me? There are two ways that stem cells can be used, and I think that's important to speak to. One, stem cells are being used to replace cells. So we talked about gene therapy where you have cells, they're still there, and they just need to be jump-started. They need to be improved. But then you have advanced stages where they're, they've already lost their cells. The cells have died, and they need to be replaced. And so stem cells are being used in some disease states where there's complete atrophy or loss of the outer retina, namely like age-related macular degeneration. There's a big trial that's ongoing currently. The National Eye Institute is leading the efforts there. However, for RP, inherited retinal diseases, not necessarily, that's not necessarily how stem cells are being used. But there are some trials where the stem cells are being injected into the eye, not for replacement purposes, but because they can serve as a living factory of good growth factors.
Okay.
Going back to growth factors could potentially be beneficial, right? To decrease inflammation and oxidative stress. So there are ongoing efforts right now and active clinical trials for that. So that's kind of exciting as well. And then there's optogenetics.
Yep.
Right.
I've heard that one. Yeah.
So optogenetics currently being tried for advanced form of retinitis pigmentosa, Stargardt disease. And so it's important to really understand what optogenetics is. So for most gene therapies, we're targeting the cell that has the missing protein, where the gene is dysfunctional. And so the cell is not functioning appropriately. But for optogenetics, you can actually use it as a gene agnostic therapy.
Yes.
Right. And so to understand, you can kind of think about the retina. So the retina has the inner retina, which is connected to the brain. And then the outer retina, which is what initially senses the light. It's light sensing cells. And that becomes essentially like an electrical circuit. Senses the light, sends it to the inner retina, and then sends it to the brain. It's this beautiful electrical circuit. But for patients with RP and other inherited retinal diseases, the outer retina is either dysfunctional or missing, especially in advanced stages. That outer retina might be gone completely. But those patients might have really healthy inner retina. And oftentimes that's the case where the outer retina is gone, the inner retina is preserved.
Okay.
And so the inner retina in general is not a light sensing layer, right?
Interesting.
Yeah, it's just there to be this circuit to send the signal to the brain. And so for optogenetics, it's a form of gene therapy where you are actually making the inner retina light sensitive.
Oh, okay.
Okay, so you are actually infecting those cells, not with a gene that the patient's missing, but you're infecting the cells to produce an opsin, a light sensing protein, which then can allow light sensitivity and, circuit initiation.
Kind of makes them dual function essentially at that point.
Exactly.
Interesting.
Yes. So there have been select group of patients treated with this. They're still in early stages, phase 1, phase 2. But promising. There's been partial recovery of vision in some patients who, have light perception vision, light on or light off, and potentially now have some more functional vision. So I think time will tell whether or not it's safe, effective, and who to treat with these types of therapies. But I would say the overarching view that I have as a physician is that there's hope, and there are a lot of people studying this, and it's moving faster than anticipated. Like there's so many trials that are popping up on a monthly basis, I would say to be cautious to people who are, excited to just enroll in a trial, that with any trial that you enroll in, it potentially could make you ineligible for a future trial that maybe would be more effective.
Makes sense.
And that's science, right? And so clinical trials are done to figure out if something is safe and effective. And I just think that's important to say as as we're trying to figure this out.
That's a really great point.
Yeah. And then gene therapy, to go back to that, because I think it's kind of a hot topic, and for a good reason, right? It has a huge advantage and potential to affect change. Gene therapy can be delivered in a lot of different ways to the eye, whether or not it's just an injection inside of the eye or it's injected underneath the retina, which is not necessarily an easy task. It's a big surgery.
Yeah.
And we can talk about that later. But there are other approaches that are being tried. So they all have their risks and benefits.
Absolutely.
Yeah.
Wow. Okay. A lot to unpack in that answer. There's so many fascinating things I could talk about for so long. So before I ask a little bit more about gene therapy and specifically Luxturna, which I want to get into, I want to go backwards into a foundational question, because you mentioned retinitis pigmentosa a bunch of times. And this is one question that we get a lot and that there's some confusion about is retinitis pigmentosa. In my understanding, is that it's a group of conditions and not a single genetic cause of a condition. So people who say they have retinitis pigmentosa, they're not all the same. There's a wide range. So what's kind of the scientific way to think about it, and what's a good layman's way to just think about what is retinitis pigmentosa and understanding the underlying causes that lead to the clinical syndrome of retinitis pigmentosa?
Great question.
Yes.
So RP, I like to think of as an umbrella.
Yes.
And there are multiple spokes of that umbrella. And those are the 300 genes, 300 plus genes that are quote unquote RP genes. Okay. And so RP essentially is looking at the patient and saying, clinically, you look like you have retinitis pigmentosa.
Yeah.
Clinically, I look in the back of the eye and I see these bone spicule-like pigmentation, which are pigmentary changes in the back of the eye. Potentially, there's some changes to the blood vessels in the back of the eye or the optic nerve that all together kind of look like RP. However, it's sometimes impossible to look in and say this patient has RP related to this gene.
Sure.
Sometimes we can.
Yeah.
Sometimes we look in the back of the eye and we're like, oh, this is a very specific form of RP that really looks like this gene. And you can just test for that gene and potentially get a yes or no answer. But the vast majority of cases we look at and we're like, okay, it fits the triad of RP, or just in general, we want to test for all of the RP genes.
Yeah.
And so that's where targeted gene panels come in, where there are 300 plus genes that we look for. And it's not like we're testing every gene in the body. We're just testing genes that potentially could come back positive for this patient based on the clinical history and exam. So I think that's important to know, but there are different categories when you see a patient. So you want to ask them specific questions to really understand, does this patient have RP and which gene is affecting them? So we ask questions like, do you have hard time seeing at night? Can you see the stars, right? Is your peripheral vision being lost? Do you have tunnel vision? And that all kind of helps us get closer to the answer. But then there's also syndromic forms of RP and non-syndromic forms of RP. So as a clinician who treats patients with IRDs, we have to be very good diagnosticians, asking a lot of different questions to figure out what the answer is. And also, should we refer them to other specialists?
Yes.
That's really important. RP care is not just eye care.
Correct.
So I guess that's the first start of that question.
It's perfect. Perfect. And then the one quick follow-on question to that is, so I have a son with BBS1. And a lot of the people that follow us and are interested in what we're doing come from the BBS community. So does BBS vision loss fall under that umbrella of RP that you talked about?
It's a good question. So RP, when you when you think about RP, likely what people are thinking is tunnel vision still has really good central vision.
Mm-hmm.
And oftentimes that central vision is maintained for the majority of someone's life. And so the answer is a little bit nuanced.
Yeah.
With RP, because there are so many genes affected, there are a lot of different phenotypes, which is how they present, right, clinically. And so there are some patients with RP who have very early onset RP and lose their vision very early. Some even as early as, 1 or 2, they have no vision at that point. And then there's the other end of the spectrum where there's late onset RP. I have patients who are 80 and I diagnose them with RP and they never knew, nor will they ever have symptoms related to it.
Interesting.
They have 20/20 vision and they're living their life not knowing.
Yeah.
Okay.
Yep.
And then there's everything in between.
Yes.
And RP is definitely nuanced where there is central vision loss in some cases, right? Ranging from atrophy, which is that loss of the outer retina, to just forms that have more central and peripheral combination. And so LCA is kind of a broad, also an umbrella term, where essentially means early onset, decreased vision, including central vision.
Okay.
Usually associated with early nystagmus too, where the eyes are shaking, a little bit. So it's, BBS definitely falls under RP and is similar to LCA. In fact, there's a lot of overlap on the two. But it's not one fits all.
No.
Right? You have to really understand which gene, and even BBS, as you know, BBS 1 looks very different than BBS 10.
Correct.
It presents differently. It has different syndromic manifestations.
Yep.
And so understanding the genotype-phenotype relationship is really important for us as a community.
Correct. And that's exactly what I wanted to get to, is because we get that question a lot, is like, I've been told I have RP or I've been told I have BBS, and like, are they the same? How are they different? And that's a really helpful answer to know kind of just what the right way to think about it is, because there is some confusion over that. So I think that's a really great topic to understand. So moving back into kind of the treatment realm. So you mentioned Luxturna and LCA, and that Luxturna is the only FDA-approved gene therapy right now. So what's your experience been treating patients with LCA, and what does that treatment and the response look like for those patients?
Great. Thanks for asking the question. This is a really exciting part of our career. And I told you I was at Iowa for residency, and that was when the clinical trials were being done for this medication. Steve Russell was the lead author on the Lancet publication back in 2017, and he was one of my attendings at the time. So it was amazing to kind of be right next to him, seeing these patients, right, before and after surgery. But when I was at Casey as a fellow, Luxturna surgeries were pretty common. We had several a year that we did, and it's such a powerful experience. I would say seeing these patients postoperatively is one of the highlights of my life, not just my career, of being human.
Yeah. Wow.
So just like a personal experience, I had a patient who was blind from LCA related to RPE65. And just a reminder to those who are listening, Luxturna is a very specific gene therapy only to patients who have biallelic RPE65 variants.
Yes.
So this patient who was treated, I was talking to him before surgery, talking to him after surgery. He had never seen his wife's face, nor had he seen his children's face ever.
Wow.
And then after surgery, he knew what they looked like.
Oh my God. Choking me up thinking about that. Oh my God.
He also told me that the furniture in his house was horrible to look at.
Oh my God.
It was like his world opened up. Colors were vibrant again. And it's just, it's hard to put into words how powerful that experience is as a clinician. And we at Mayo were just going through the process of being a Luxturna site. So it takes a lot to become a Luxturna site. It really does. And for good reason. You want to have a well-coordinated system and team. These are not surgeries to take lightly. They're big surgeries. They require, trained nurses and anesthesia team and pharmacists, everyone who knows how to prepare and process and handle this medication. So yeah, happy to talk about whatever aspect of Luxturna care that you would like, but I would say that's the number one thing that I wanted the audience to hear, is that this is a medication that is doing a lot of good.
Wow. Okay. Well, one thing that kind of struck me on that is that, you mentioned that when you're giving a gene therapy, you have to have the real estate to preserve. You talked about essentially a rescue of some vision. Basically, he had this, hadn't, seen his wife's face and his children's face, and then the therapy is given, and now he has some restoration of vision. So what do you think is the underlying kind of pathology or pathophysiology or mechanism of how that happened with, the vision's not there, but he must have some preserved real estate, obviously, for that target to be given. So is there like a quiescent period where the cells are not working, but they haven't been lost and degenerated yet? Or what's kind of your thought there?
Yeah, correct. So the package insert on Luxturna really takes into consideration that the physician has to make a decision whether or not there are enough cells to treat this patient. Okay. So not everyone with RP65 related LCA is a candidate for Luxturna, because if there are no cells to treat, then gene therapy is not going to be helpful.
Yeah.
And then we should not put those patients at risk and through a surgery.
Sure.
But as a physician and as an IRD community, we can look in and do testing, including retinal cross sections and various tests like electrophysiology tests, et cetera, to figure out if these patients are potentially eligible. And in many patients, in many cases, there are cells that are present and are able to be infected. I'll use that term.
Yeah.
And so for RPE65, it's a really important enzyme in the visual cycle.
Okay.
And so if it's not functional, the visual cycle is just not going at a high enough rate to process, all of the light and objects. But once you turn it on, the visual cycle essentially turns on.
Wow.
So as long as the cells are present, then it's honestly a miracle.
Rescue.
Yeah. There have been some post administration studies that are coming out. Actually, this is all very recent. There was one that was published a few months ago for the non-US sites, and then the US site data will be coming out soon, I think this year. But all to say, Luxturna has been analyzed, the outcomes have been analyzed. And even though I provided that story about patients, the vision improves some, at least if you look at the graph.
Yeah.
But it's really the retinal sensitivity that improves.
Okay.
And the quality of vision.
Okay.
So if you look at the visual acuity before and after, it doesn't look that striking if you look at all of the patients treated. But if you really ask on an individual level and really think about how the eye is processing and the visual cycle, it's just better quality of vision, improvement in their sensitivity.
And then it also halts the further loss of vision. So like if you gave it to somebody today, they shouldn't have a further loss of vision. Is that the correct way to think about it?
Time will tell.
Time will tell.
Yeah. that we hope so.
Yeah.
Right. Right now it's 2024. Luxturna was approved in 2017. So there are many patients who still have full effect at this point.
Okay.
So who knows what it's going to look like
long term, but short term that we have.
Short term
years of
looks
data
promising. Yeah. Will the patients need to be redosed in the future? I think that might be something that we would have to consider if we start to see the effects start to decrease.
Yeah, fascinating. All right. So one of the hallmarks of, every treatment is risks, benefits, and alternatives. So we obviously talked about the benefits pretty extensively. Alternatives are none because there's no other treatments for most of these conditions. What are the risks? Or like Luxturna specifically?
Of Luxturna, sure.
Yeah.
Okay, so talking about the risk, really, we have to start with the surgery. Like, how do we actually do the surgery?
Mm-hmm.
Right. So I'm a vitreoretinal surgeon. Anyone who does the surgery is going to be similarly trained, where you go through a vitreoretinal surgery fellowship.
Mm-hmm.
And so, in order to get to the back of the eye to treat the retina, you have to take out the jelly in the eye, which is the vitreous.
Okay.
So that's why we're called vitreoretinal surgeons.
That's why you do what you do and I don't.
So, I'm happy to go through the details, but in order to take out the jelly, you have to go inside of the eye.
Okay.
Right.
Yeah.
So it's a major surgery.
Yeah.
Once the jelly, the vitreous is removed, then we have access to the back of the eye. Okay. So how Luxturna is administered is a subretinal bleb. And that bleb term is essentially a localized retinal detachment.
Okay.
So how we do this is with this very, very small cannula, right? The cannula penetrates through the retina. So we make a little retinotomy, which is a little hole that goes through the retina and right to that potential space between the retina and then the RPE, which is what the retina sits on.
Okay.
And so the medication essentially dissects that plane between the retina and the RPE, making a little bleb of fluid. I like to think we make a little blister.
Okay. Yeah.
A blister of medicine.
Fair.
Right. And it's not much medicine. It's usually about 300 microliters.
Okay. It's tiny.
Yeah. And so the goal is to treat the real estate that's there to the cells that need it, which is usually the central macula.
Okay.
So the risks are a few. And, I told you, a few minutes ago that I've seen a lot of gene therapy surgeries, but even 70 gene therapy surgeries is really not that many. If you want to think about complications, you really have to see hundreds and hundreds of cases to see complications. But I have seen several, just in general of assisting, and I've read all of the literature, so I can kind of speak to the prevalence in the world of all of these surgeries. And some of it has to do with the surgical technique of literally penetrating the retina. That retinotomy itself can sometimes cause problems.
Okay.
You can have little bleeds at the site of the retinotomy. Not super common, but it can happen. But also detaching the retina and making a retinal detachment usually goes very well. Subretinal blebs are honestly fairly straightforward.
Okay.
And as a vitreoretinal surgeon, blebs are fairly easy to accomplish.
Okay.
I guess you have to trust me.
I trust you on that one because that's way above my pay grade.
And in general, they do great. But post approval, so post FDA approval, we as a community have seen that there is some atrophy that forms around the bleb and sometimes in the bleb. And in some patients, it's progressive, where the atrophy, which is pretty striking clinically, has these blind spots that continue to get bigger.
Okay.
And so we as a community are trying to figure out why. Why is this happening? Is it because of RPE 65 specific disease? Is it unique to those patients? Is it because of the surgical technique? Is it because we're detaching the retina and maybe there's some type of technique flaw? Or is it the gene therapy itself, right? Is the virus, this is gene therapy is
a virus, yeah.
Yeah, it can be viral. And in Luxturna, it's an AAV, adeno-associated virus, type 2. But yeah, is it the virus that's so highly concentrated in that potential space that it leads to, overexpression and possible toxicity to the photoreceptors and the RP? There are a lot of people studying this, but in, looking at all of the patients, the prevalence is probably somewhere between 12 and 20% of patients will ultimately develop some type of atrophy.
Okay.
And a lot of times it's not going to be significant, but again, we're only a few years out. So is this going to be progressive to the point of needing to, think about other alternates? Maybe.
Okay.
And so there are a lot of people trying to figure out alternates to subretinal blebs. Also, when you make a subretinal bleb, you have to be very, very careful to not stretch the retina. Again, it's a blister, right? You're so putting the medication under the retina and it's getting bigger and bigger as a blister. And so if you go too fast or if you make it too tall, you could potentially cause like a hole through the retina, like a macular hole. And so a lot of us as surgeons, when we do subretinal blebs, we do it under direct visualization with OCT, which is cross-section scans. And we can do that at the same time that we're operating.
Wow.
We can actually see how much stress we're putting on the retina as we kind of expand that space.
It's like interventional radiology for
It
ophthalmology.
is. It is.
I like it. Image-guided procedure.
Uh-huh.
Yeah,
Yep, absolutely. So yeah, that's how we do the surgery. I would say in general, it is safe. And lots of people are doing these blebs. It's standard of care at this point. And the reason why blebs are performed is because it really allows you to put it at the site of the target, right? Which is the RPE for Luxturna. And it potentially decreases the risk of inflammation because you're not putting it directly inside of the eye. You're not putting it in the bloodstream. It's safe and confined.
Fascinating. Well, thank you for kind of giving that overview, the risks and the procedure and how that all goes. So I know you're beyond just being a clinician, you're a researcher, obviously, as you mentioned. So are you doing any work on topics related to gene therapy, delivery, or otherwise?
Yeah, thanks for the question. Yes. So kind of speaking to the possible downsides to subretinal bleb. And don't get me wrong, I do subretinal blebs, right?
Yeah.
We have to. This is how we do these surgeries.
Absolutely.
But I think it's always good to figure out how we can do things better. I think anyone would agree with
That's
that.
the basis of science is like you do something and then how do you make it better? Then
Right.
How do you make it better? And you're always constantly improving.
Exactly. So with that in mind, it would be really wonderful if we could do the exact same surgery without detaching the retina.
Right. That makes sense.
It makes sense. So think about a patient who has RP, severe RP, but still has good 20/20 vision. But their vision is through a straw, right? But if you check them on the chart, 20/20, which is normal vision, but their peripheral vision is gone.
Yeah.
So the real estate that they have for treatment for gene therapy is right in the center, which is the macula. So for gene therapy, we have to detach their only seeing retina.
Yeah, I can see where that goes. Yeah.
Yeah. And this is what we do.
Yeah.
This is the hard part of our job is to figure out who's eligible and then to walk these patients through the risk and benefits. And so my lab, which is the Mayo Retinal Regenerative Medicine Lab, we are focusing on possible alternates to avoid subretinal bleb formation. And so it's exciting to talk about this, but one alternate approach is to put the gene therapy, the viral vector, inside of a biodegradable implant.
Wow.
And then that can be literally stuck on the top of the retina, on the inner surface. No needles through the retina or detachment of the retina needed.
Wow.
And because it's highly concentrated and kind of time released over time, it's not as inflammatory as an intravitreal injection. And so it still will require a vitrectomy where you remove the jelly, but then the sticky patch with the gene therapy would just go right on the retina. So this is something that we as a team, me and my partners, Dr. Alan Marmestein and Ray Ayazi, are developing. And we've tested this on pigs and we are moving forward with product development.
Well, that is absolutely fascinating to hear about the work you're doing and where that's all going. So to turn the topic a little bit to what our community is really super hyper-focused on, I'm a father of a patient with BBS1, and that's kind of the basis of why we got into this nonprofit work. So can you tell me a little bit about your experience with treating patients specifically who have BBS and what resources you may know that exist for those patients?
Sure. So I am a physician at Mayo, and Mayo is a very well coordinated center where we have all of the subspecialists. And so kind of going back to BBS and how it potentially differs from other types of RP, I think that's really important to speak to when I'm answering this question, because BBS, there are over 20 types and 20 genes plus that can lead to BBS, syndromic RP. And every BBS type is different and requires different coordination of care and referrals. And so I feel very fortunate that I'm at an institution where there are those subspecialists. I mean, even down to neuropsychology and, ranging from cardiology, cardiovascular surgery. A lot of BBS patients have congenital heart defects and need pediatric cardiovascular surgeons. And then, ranging from gastrointestinal disease specialists and kidney disease specialists, both nephrologists and urologists. The list goes on, geneticists, dental care, etc. So based on the BBS type and the findings and the manifestations, we need to make sure we're providing the best care possible. So at Mayo, because of the good coordination of care, we do commonly see patients with BBS because we can provide the care that they need. We are not too far from Marshfield. And so I think we're 3.5 hours away. And so we have had patients, between the two sites, Marshfield being, the only center for excellence for BBS up until last year. And the huge CRIBS database came out of Marshfield. And so there are a lot of patients who come to the general vicinity and often come to Mayo for their, subspecialty care from Marshfield. So with that said, Mayo is now a center of excellence for BBS. There are 8 centers that are now being designated as centers of excellence for BBS. And that is something that is brand new. So we just kind of started these efforts in the last few months, all kind of coming out of necessity, right? These patients need access to good institutions that have good coordination of care with a lot of subspecialists who can do this in a timely fashion. And so I'm one of the pediatric retina specialists and inherited retinal disease specialists who will see these patients. And how it works is these patients come, potentially will have 3 to 5 days of care where they see all of the specialists that they need. And if there are new things that come up, we have kind of slots ready to fit in whatever's needed in that time period, and empower them with knowledge and next steps, and make a plan, if you will, for them to go home for care with their local doctors, and make sure that local physicians and providers are ready to take on the care locally. So I feel honored that I get to be a part of a system that, allows really good care for patients with BBS.
Wow. Well, that is certainly reassuring from a community standpoint, because certainly one of the first things that we found out as a family ourselves when we got this diagnosis was that there's just such a limited availability of options to go to. And Marshfield was the only one for such a long time. And, we need more. So it's so reassuring to know that you guys are doing that and there's others doing it. Follow-up question to that, beyond obviously the direct patient care side of all this, is do you think that will help translational studies? That's certainly what our organization is really kind of focused on, is helping provide treatments and, push along new research. So having a center of excellence like that, especially at a institution like Mayo that is so well coordinated, do you think that will help facilitate new therapies coming out for BBS patients?
I know it will.
Yeah.
Absolutely. So in order to develop new therapeutics, you have to have really good disease characterization, right? And that requires coordinated efforts. It also requires partnerships with scientists. And so at all of the centers of excellence, it's not just the clinicians that are patient facing, but it's also the teams behind the scenes who are doing the work, doing organoid work, doing stem cell work, doing disease modeling and animal work. And so I think the answer is a resounding yes, that the more institutions who are centers for excellence and who are thinking about this all the time and have the patients, that those are going to be the teams leading the efforts, moving the science forward, and potentially being the primary sites for phase 1 trials.
Well, yeah, that seems to make total sense, and that's exactly what's needed. And then it seems like what would also be, important with that is once you actually get to the point of having a trial is having the resources to carry it out, because I'm not involved in clinical trials. That's not my expertise, but I know that it's very complicated. I know that it takes all kinds of stuff from support staff to planning to the pharmacists to all the teams to the surgeons. And you can't just put that together at any old place. So like, it seems like that would be a really big benefit to once those therapies actually get to the point of becoming a trial.
Mm-hmm. Yeah. And I think it's also important to remember that gene therapy in this case might not just be in the eye. Right. And so having coordinated efforts of multiple different specialty surgeons, whether it's neurosurgery or interventional radiology or vitreoretinal surgeons, having an institution that can use the same gene therapy in various routes of administration is going to be extremely important.
Yeah. And that's certainly one thing that, I just had an interview with Dr. Phil Beals, and he, relayed to me some of the research he's doing on the hyperphagia component of BBS. And so I know he's working on some therapies related to that. So certainly having those kind of interdisciplinary options with different specialties, different disciplines will certainly be, seems like it would be very advantageous for advancing the therapies and treatments.
Yeah, absolutely. And, I didn't mention endocrinology, but obviously that's a huge division and specialty that's important in these children. And at Mayo, we have a huge pediatric endocrinology division. And now that there's a medication to offer for BBS related obesity, it's important to be able to offer that to these patients, for sure. So
before we wrap up, I'd love to know how patients with BBS can get in touch with your clinic, and how they can, or how clinicians can refer to your clinic.
Yeah, great. So every center of excellence for BBS will have a coordinator.
Okay.
And so at Mayo, we have a coordinator, and I'm happy to give you that information. We can share that with whoever is interested. We also have a website that is in process.
Okay.
Because this is new efforts. These centers are currently right now being started. We just started recently in April.
Okay.
So hoping to have that website up and running to have more information, but happy to provide that.
Perfect. So when we get that information, we will make sure it's in the show notes so that patients and clinicians who want to refer to your guys' multi-specialty clinic will be able to do so.
Sounds good.
All right. Well, thank you so much for being here. Thank you for not just the work you're doing, for dedicating your life to these rare diseases and these patients who may otherwise be left out. And thank you for the work you're doing with BBS. And that's going to, impact our family, our community, and everything you're doing. So from the bottom of our hearts, thank you.
Welcome. Thank you.
Thank you for listening to my conversation with Dr. Brittni Scruggs. If you want to learn more about anything you heard in the episode, head over to our website at eraseagainstblindness.org, and also check the show notes to find out how you can get in touch with her team at the Mayo Clinic. Thank you so much for watching.